5, 4, 3, 2, 1. Good morning. I call this hearing to order. A quorum is present, and without objection, the chair is authorized to declare a recess at any time. The committee procedures for remote hearings remain the same. If you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so these issues can be resolved immediately. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearings@mail.house.gov. Without objection, members will be recognized in order of seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the procedures for this hearing? Hearing none, we'll proceed. I will now recognize myself for an opening statement. For years, this committee has prioritized, passed, and sent to the White House major pieces of legislation aimed at preventing suicide and helping veterans create lives of purpose, meaning, and joy. But we know that our work is not done, and today's full committee hearing will review the science-based best practices of VA's current public health model and hear about new innovative approaches, including those from the new Suicide Prevention Community Organization grant awardees. And one of the most important things we can do when talking about suicide prevention is to offer hope. It is my hope that the information and insight gathered today will strengthen the committee's development and implementation of life-saving policies that reach each and every veteran. And I'm confident that the research, outreach, clinical services, crisis response, and policy work we all do offers hope to veterans who may otherwise feel hopeless. As policymakers, part of our duty is to walk alongside those who carry heavy burdens, often related to their military service, and help connect those seeking more purpose and joy in their lives to new opportunities through which they can thrive. Last week, VA released its annual veteran suicide report, leading with what it calls anchors of hope. Although we all know that losing one veteran to suicide is one too many, I was encouraged to see that the rate of veteran suicide dropped in 2020 for the second year in a row, despite the pandemic isolation. Also encouraging was the particularly dramatic rate of decrease in veteran suicide deaths among women veterans. While these data do offer hope, veterans still die at higher rates than their non-veteran peers, and suicide is the second leading cause of death among veterans under age 45. And so we come together again this year during Suicide Prevention Awareness Month to take stock of what is working well and urge VA and its partners to capitalize on those efforts to reach even more veterans in need. I hope that all of us now have the new 3-digit national crisis line 988 memorized and in our phones. Veterans dialing 988 can still press 1 to reach the Veterans Crisis Line. Staffed with responders specially trained in the often unique needs of military service members and veterans. I applaud VA for transitioning smoothly and effectively to the new number and encourage those in crisis or those who may know of someone in crisis to utilize this resource. VA has also announced that it has selected 3 VA facilities to receive new range centers as Congress mandated in Congresswoman Axne's Sergeant Ketchum Rural Veterans Mental Health Act last year. 27 VA medical facilities competed to get one of these 3 new centers, which tells me that they see the need for this kind of intensive outpatient wraparound case management for veterans with serious mental illness. It also tells me that we should be funding and developing more range centers in our rural areas to serve even more veterans through this successful program. Now, there is also evidence that VA could more broadly expand its efforts to train staff and talk with veterans about lethal means safety. Data show that safe storage of firearms could drop the veteran suicide rate even further. I would also like to see VA finally require that its community mental health providers who are paid by VA to treat our nation's heroes receive even a minimum of the same mandatory training VA providers receive in evidence-based approaches to treating PTSD, military sexual trauma, traumatic brain injury, and suicidal thoughts and behaviors. We shouldn't be sending our veterans out into the community to mental health providers who are less equipped clinically and culturally to provide high-quality care, the high-quality care our veterans have earned and deserve. Now, I don't want today's hearing to be solely focused on what VA has already put in place, though your comprehensive efforts are truly impressive. We also want to look to the edge of innovation, where VA's researchers and clinicians often shine. So what does research tell us about alternative approaches to treating mental health challenges? How can your newly announced community grantees through the Staff Sergeant Parker Gordon Fox program partner with VA to extend your reach to those veterans not yet in VA care? How will your Mission Daybreak Grand Challenge take us far beyond our current limits and approaches, especially by harnessing technology? Finally, I want to hear from VA about when we can expect the key provisions of my Veterans Compact Act, free suicidal stabilization care wherever veterans show up in crisis, to go live. Now, Ranking Member Bost, that concludes my remarks. I now recognize you 5 minutes for your opening remarks.
Yeah, thank you, Mr. Chairman. Good morning, everyone. I'm glad to be here today to discuss a very important topic, veteran suicide prevention. Suicide is a complex, difficult public health problem. Last week, VA released the 2022 National Veteran Suicide Prevention Report that contained veteran suicide information from the year 2020. According to the VA, veteran suicide decreased by 343 individuals from 2019 to 2020. This brings the total number of veteran suicides deaths down to 16.8 per day in 2020. But sadly, it is yet another year with more than 6,000 veterans suicide deaths. In contrast, America's Warriors Partnership recently completed a study that indicates that the VA is likely undercounting veteran suicide deaths. The AWP arrived at this conclusion by looking closer at state-specific demographics and military experiences and death details. And according to the AWP, the actual number of veterans who died by suicide between 2014 and 2018 was closer to 24 per day. In comparison, VA data shows about 17.7 veterans suicide deaths per day over that same time frame. Unlike AWP study, the VA data does not include deaths by overdoses or certain injuries, which are likely considered accidents. Admittedly, that data is hard to capture, but the scope is sobering. And either way, both numbers are unfathomable and unacceptable. It is our responsibility as members of this committee to do everything in our power to support veterans, to make sure that they have what they need to heal and move forward. That's why Congress acted 2 years ago to create the Staff Sergeant Parker Gordon Fox's Suicide Prevention Grant Program. The Fox grants will expand support for suicide prevention outside the VA walls and into local communities. We know that most veterans who die by suicide are not actively engaged in VA care. Every effort must be made to reach out to veterans where and when they need help. Community partners can be there to save lives. VA announced the Fox First Grants recipients last week, and some of them are testifying today on our second panel. One of those witnesses is Jim Loran, the CEO of the AWP, who is testifying today for the minority. By taking on this sacred responsibility, he and his fellow second panelists are yet another resource ready to lift veterans out of isolation, get them out of trouble, and get them the care that they can and save their lives. I look forward to listening to and learning from them today. Now, if you are a veteran watching this right now who needs help, please know help is available to you anytime by calling 988, pressing 1. Once again, call 988 and pressing 1. You can also text, and as soon as I separate this paper, I'll tell you where you can text. Text 838-255. Again, that's text 838-255, or visiting the veteranscrisisline.net. With that, Mr. Chairman, I yield back and look forward to our witnesses giving testimony today.
Thank you, Ranking Member Bost. I call up and recognize our first witness panel from the Veterans Health Administration. First, we have Dr. Dr. Tamara Campbell, Acting Executive Director of VHA's Office of Mental Health and Suicide Prevention. Actually, I think it's Tamara, Dr. Tamara Campbell. I did exactly what I didn't want to do, which is to say it the wrong way. So it's Dr. Tamara Campbell. She is accompanied by Dr. Matt Miller, National Director of Suicide Prevention, and Dr. Lisa Brenner, Director of VHA's Rocky Mountain Mental Illness Research, Education, and Clinical Center for Suicide Prevention. I want to thank you all for being here, and I will remind our witnesses to pause 2 to 3 seconds before speaking and answering questions. Dr. Campbell, I understand this is your first time that you have testified before Congress. On behalf of my colleagues, welcome to the Veterans Affairs Committee. We look forward to talking with you today and continuing to work on veterans' mental health issues, and I apologize for mispronouncing your name the first time. Dr. Campbell, you are recognized for 5 minutes to present VA's testimony.
Good morning, Chairman Takano, Ranking Member Bost, and distinguished members of the committee. Thank you for the opportunity to discuss the department's efforts to reduce suicide among our nation's veterans. Accompanying me today, as mentioned, is Dr. Matthew Miller, Executive Director, Suicide Prevention, and Dr. Lisa Brenner, Director, Rocky Mountain Mental Illness Research Education, both programs within the Office of Mental Health and Suicide Prevention. On behalf of the department, I want to thank this committee for its continued support on reducing veteran suicide. This critical relationship is reflected in the resources that Congress has repeatedly secured for VA and OMHSP. It is a priority of this administration to address the national mental health crisis, as seen in President Biden's budget request of $13.9 billion for VA mental health care for fiscal year 2023. In 2020, 6,146 veterans died by suicide. These numbers are more than statistics. They reflect individual lives prematurely ended, which continue to be grieved by family members, loved ones, and the nation as a whole. Suicide is a complex problem with a multifaceted interweaving of potential contributing factors. With no single cause, there is no single solution for suicides for veterans. Last week, we released the 2022 National Veteran Suicide Prevention Annual Report. Our methodology for generating this report is well established and consistent based on verified data from the CDC and DOD, and meets the quality and standards of a peer-reviewed publication. With each of you, we are fueled by the anchors of hope in our 2022 annual report, which found the lowest number of veteran suicides since 2006, a 9.7% decrease in adjusted rates for suicides from 2018 to 2020. And despite the onset of COVID-19 pandemic, in 2020, age and sex-adjusted suicide rates among veterans fell 4.8% from 2019 to 2020 versus only 3.6% decline among non-veteran U.S. adults. This year's report shows real progress, but there is still so much work to be done. One veteran suicide is one too many. VA is implementing a public health approach as outlined in our 10-year national strategy for preventing suicide and further informed by the White House Reducing Military and Veteran Suicide Strategy. In support of Staff Sergeant Parker Gordon Fox Suicide Prevention Grant, we announced grants of more than $52 million to 80 community partners in 43 states, the District of Columbia, and America Samoa. This summer, VA invited innovators across the country to participate in Mission Daybreak, a grand challenge designed to help VA develop new suicide prevention strategies for veterans. VA awarded $250,000 to 30 finalists and $100,000 to Promise Award recipients. VA made great strides with implementation of Dial 988 Press 1 to reach the Veterans Crisis Line. From July 15th to August 28th, 2020, VCL has received over 96,000 calls while continuing to maintain an answer rate of less than 10 seconds and exceeding all performance metrics. Several clinical initiatives are active across VHA. These initiatives support suicide prevention work and include: 1, naloxone distribution. Over 43,000 VHA prescribers have prescribed naloxone, resulting in over 3,190 reported opioid overdose reversals. 2, a commitment to whole health approach to care. 3, increased hiring of mental health staff. And 4, continuing a new pilot of innovative treatments. In conclusion, suicide is preventable, and each of us has a role to play. Mr. Chairman, this concludes my remarks. My colleagues and I are prepared to address any question you may have. Thank you.
Thank you, Dr. Campbell. Without objection, your written testimony in full will be included in the hearing record. I now recognize myself for 5 minutes, and get to my first panel questions. So, Dr. Campbell, I want to say to you, VA is now over a year late in implementing key provisions of my Compact Act, making emergency suicidal stabilization care-free or cost-free for any veteran other than those with dishonorable discharges, no matter where they show up in crisis. Now, when will VA go live with the Compact Act, which removes a financial barrier to getting help at the moment when that help is needed most?
That is a very important question, Mr. Chairman, and thank you for it. We are committed to providing medical and mental health care to veterans experiencing acute suicidal crisis, and we are ready to provide this care in advance of implementation of Compact 201. We need to ensure a seamless process so that no veteran is unduly billed, because we know from our annual report that financial stressors increase the risk for our veterans. We discovered that to make this process seamless, we need changes to the operational, financial, and eligibility enrollment systems. VA teams are working tirelessly on these issues to meet our aspirational go-live date. We anticipate winter. This time will allow testing of these processes and training of our staff. And we want to note that today our TMS training is live for this effort. We have also completed the interim final rule establishing regulatory requirements for implementation, the update to VHA Directive 1601, and we have developed communication plans and strategies, critical documentation templates, which will serve to ID compact care cases.
Dr. Campbell, I'm pleased to hear that. I wish it would be moving faster. I realize there's a lot of complexities to implementing this law and to enforcing this law, but it's really important that we get this and get it right. I'm pleased to hear that that you're offering this care now, even though that it's not operational, that veterans can call the crisis line and be put into care and know that that care is not going to cost them money for the first 6 months. That's really important. We also know, and I know you know, as we're concerned about the rates of veteran overdose deaths, as we are about veteran suicide, we're just as concerned about those overdose deaths as we are about suicide deaths. And we understand that sometimes it's difficult for coroners and local medical examiners to determine intentionality related to an overdose death. VA reports deaths in both categories. And while it is important to not fully conflate the two, can you say more about what VA is doing in collaboration with DOD and the CDC to better prevent and classify what the Surgeon General has called deaths of despair?
Yes, sir. Yes, Mr. Chairman, another great question, and I will defer to Dr. Lisa Brenner.
Thank you so much for the question. I think that what we know is that health outcomes, and particularly negative outcomes, travel together. We see this in physical health, and we see this in mental health. And so in the case of suicide and opioid overdose, they often travel together. As such, we're consistently engaging in increasing our understanding of how to understand the Venn diagram of the two and identify individuals who are at risk for both. Doing this really helps us increase our ability to accurately identify veterans who may be at risk for suicide and or opioid overdose, and create decision support tools and other materials that can be used by clinicians and members of the community to create increased awareness at the point of care. This includes things like STORM, which is a stratification tool for opioid risk management. It's on all clinician desktops. This decision support tool has been implemented and been found to decrease all-cause mortality by 22% amongst veterans. So it's this kind of integrated thinking that we continue to work with DoD to identify those at risk.
Well, great. But can you tell me, it is difficult to distinguish between the two, but is it appropriate? I mean, do you think there's any harm in conflating those numbers?
I think it is difficult to identify which one is happening at times, and at times people need different interventions specifically. So I think there can be challenges with differentiating, and that is certainly what we're engaged with in terms of working with our partners across the federal system to help educate, decrease stigma, and increase accuracy and identification at time of death. At the same time, this is an ongoing challenge for us.
Do you have any guidance for coroners, or does VA have any guidance that you might give to coroners? Because what I hear you saying is that making this distinction is important in terms of the intervention.
Correct.
That to label all deaths by overdose would cause us to have an inappropriate intervention. To just say that all overdose deaths are about suicides will lead us to some level of ineffectiveness. And therefore, is there any kind of guidance you might have to give to coroners based on, your experience and how we treat veterans?
So that would be something that I would have to take back and provide with feedback after the session. But I think this is an ongoing thing that we are working on, and certainly related to decreasing stigma and helping individuals understand that identifying individuals at risk for suicide or who have died by suicide is an appropriate thing to do.
Well, thank you. I'm very troubled by what I see going on with fentanyl and everything going on. And it strikes me that not all of these deaths by fentanyl are intentional suicides. That some of these are just the nature of the evil nature of this beast we're trying to deal with. But I've gone over time, but I felt it was an important line of questioning. Ranking Member Bost, I recognize you.
Thank you, Mr. Chairman. Dr. Campbell, the committee has been made aware of a veteran living in Maine who's lost limbs and suffered from post-traumatic stress as well as substance use disorder. He has been trying to seek residential treatment from the VA, and he was initially denied that option of seeking the care outside of his outside of VA near his home, which he would have preferred. The VA later agreed to send him to a VA facility in New York, multiple states away, but only for his addiction issues. VA said that he had to be, quote, unsuccessful, end quote, at the VA facility first before he could be referred to a community care, into the community for care. In the intervening time, the veteran attempted to take his own life. I have some questions about this case, or about why we handle the things, the way VA is handling some of this. Why does a veteran with multiple complex physical and mental health conditions who is actively seeking help have to travel across multiple states and be unsuccessful in a VA treatment program and then attempt suicide before the VA will honor his request to seek care in the community?
I appreciate that question, Representative Bost, and that is a very critical area that we're looking into. Access is a dynamic process, and it depends on the geographic location and the specialty service required. And so within mental health, we do both primary care and specialty services combined in one office. And we look at it in terms of emergent, urgent, and sustained treatment. This particular treatment that you're referring to, I don't know the specifics on this case. I'll be happy to dig in and get back with you. But it sounds like it was a case of sustained treatment, that the person was not in acute need. And so with the current surges, at times, we may not have access in a particular location because we still have to make sure that the veterans are safe in terms of COVID precautions. But again, I don't know the specifics of this case, sir. I'll be happy to look into it.
That's fine. We'll have staff reach out to you on that one. Also then, just to let you know, Leader McCarthy and I held a VSO roundtable last week, and the VFW recommendation to us was that the VA incorporate VBA's data into their annual suicide prevention report. Why doesn't the VA include that data in its current report?
I will defer that to Dr. Miller.
Okay.
VBA data is included in the current report. For example, in the current report, you'll see that 36.3% of veterans had VBA contact in the year of their death or the year prior. So again, it is incorporated. Thank you.
That's good. That's good to know, so I take back to them. I'm really having trouble with these papers today, I tell you. Dr. Campbell, can you give us an update on the feedback you've received at VA Medical Center leadership or from how the field, how the rollout went with the 988 system?
Thank you for that question. I will say a few remarks and then turn it over to Dr. Miller. Overall, we had a very successful rollout as was anticipated. Our team had been working for 2 years to make sure that we had a successful rollout of 988 Press 1, and I'll allow Dr. Miller to continue. Thank you.
Thanks, Dr. Campbell. Briefly, I reiterate and reinforce that we have had a very successful implementation of 988 with full thanks to our leadership and to the VCL team led by Dr. Lisa Kearney. Evidence of a highly successful implementation. We've gone from averaging about 1,900 calls per day to averaging 2,165 calls per day for about a 10% increase overall. All the while, our answer rate has improved. It's gone from 98.3% to 98.4%. Our service time, our service level of 20 seconds or less has improved. It's gone from 96.1% to 96.3%.
I appreciate that. Mr. Chairman, I yield back.
Thank you, Ranking Member Bost. I recognize Chairman Pappas for 5 minutes.
Thank you very much, Mr. Chairman. And Dr. Campbell, I have a question for you. And I want to focus in on the transition to civilian life, which we know is not always easy. And unfortunately, suicide rates for all veterans, regardless of demographics, spiked during the first few months after being separated from active duty. I think that's why VBA's Solid Start program is such an essential component of VA's public health model, particularly as part of its universal and targeted prevention efforts that are geared toward populations to prevent or lower risks for suicide and are geared at those with higher identified risk, respectively. So we know that this legislation is pending on the floor right now. I commend Representative Slotkin and Senator Hassan for introducing this legislation. I'm hopeful that we can get it across the finish line soon. And I'm just wondering if you can reflect on how the provisions in the Solid Start Act will help VA's ability to support veterans during their transition to civilian life and more effectively implement your public health model, specifically regarding universal and targeted prevention efforts.
Thank you, sir, for that very important question. I'll defer to Dr. Miller.
Yeah, great question. Solid Start, I think, addresses important communication at a critical time. We all know, those of us who are veterans, the experience of TAPS and receiving a lot of information, fire hose sort of experience, and trying to incorporate it. Solid Start is highly advantageous to our veterans because it offers repeated opportunities for information, and that information tailored in accordance with the veterans' requests and needs. I think it also gets at an underlying dynamic that we know is so important with this population, and that's trust. We know that service members transitioning experience decreased levels of trust in the VA and federal government overall. Solid Start offers personal contacts that help to build that sense of trust and then in turn convert into engagement in healthcare system for prevention and intervention services.
Well, thanks very much for that response. And I wanted to turn to the issue of LGBTQ plus veterans. And one of the best tools that the VA has to combat veteran suicide is providing mental health services. But we know that the legacy of don't ask, don't tell continues to get in the way and prevent LGBTQ veterans from accessing VA benefits like life-saving mental health services, and that can have devastating effects. According to VA, LGBTQ plus veterans who could not or did not serve openly in the military experience higher rates of depression and PTSD. In fact, one study on the mental health of LGBTQ veterans found that nearly 15% of them attempt suicide, compared to less than 1% for the entire veteran population. So we have been working on legislation to address this through the SERV Act. I'm going to continue to find ways to move that legislation forward, but I think the connection here is clear. And VA's directive last year related to LGBTQ veterans that have been impacted by Don't Ask, Don't Tell was certainly a positive step forward, but I remain concerned about their plight. So I'm wondering if what resources and outreach efforts directed toward LGBTQ plus veterans as part of VA's public health model can address this situation.
Thank you for that question, sir. Very important question. And we have resources in terms of our cultural competency and diversity on this issue. And I will also ask for Dr. Miller to add more detail in terms of what's happening with suicide prevention.
Yeah, real quickly, I think one of the most important things that has occurred within the last 6 months is the creation, implementation of a clinical reminder, specifically offering the opportunity for veterans and their caregivers to talk directly about LGBTQ status and issues. That clinical reminder and completing it will allow us first to better understand population and number, and second and most importantly, to tailor services through VHA and VBA accordingly.
And also, sir, I would like to add that I think it is critical that when we hire staff, that staff is reflective of the demographics that we serve. And so we do our best to make sure that the staff who are treating our patient represents this demographic. Thank you.
Well, thank you for that. And I think continued focus on implementing VA's directive on veterans caught up in Don't Ask, Don't Tell is important, and closing those gaps in outreach is really critical to making sure that these veterans receive the mental health services that they deserve. With that, I'll yield back, Mr. Chairman.
Thank you, Chairman Pappas. I recognize the gentleman from Texas, Mr. Roy, for 5 minutes.
Thank the chairman. Thank the witnesses for being here today. Question, I think the ranking member touched on this a little bit. There were some recent studies this month about veteran suicide rates and whether or not our data is reflecting the entirety of that population. I think it's University of Alabama, some other, I don't know, several reports that came out in the last couple of weeks. What can you say about how accurate you believe, and I realize it's tough, that's not a critical question, but how accurate our data is on suicide, given the extent to which substance issues and overdoses or, poisonings if you're in the context of like fentanyl and some other things. But, how much that's being actually accounted for in our numbers. Because the numbers were pretty striking, right? Like upwards of 30 to 50%, according to some outside studies, saying not being accounted for in our data. So I'm just curious what your all's views are on that.
Thank you, Representative Roy. That's a very important question, and I will give a couple of opening remarks and then defer to Dr. Miller. Our report is scientifically rigorous, evidence-based, using the methodology as you would for a peer-reviewed publication.
Thank you, Dr. Campbell, and thank you again for the opportunity to speak to this. First and foremost, you asked about level of confidence. As a veteran myself sitting before you and a subject matter expert in public health and mental health, I would not be sitting in front of you if I did not have 100% confidence in the data that we present on an annual basis. That data, I am 100% confident, represents the fullest and most accurate information that we have on veteran suicide. There's two important points there that are critical to understand. Veteran and suicide, when it comes to talking about these other reports that have been published. There is a difference between veteran and service member in the other report. There is a difference between World Health Organization and CDC definition of suicide and overdose. The other reports have put those together, and current guidance from the CDC is that they have significant concerns about that.
And Dr. Miller, look, I appreciate that, and I'm going to make a slightly jaded point that's not directed at you, but just color me a little skeptical when I'm listening to what the CDC or NIH put out lately. I've got a few concerns about some of our public health organizations and entities in general, but in broad terms, I guess what I'm getting at is, I think you would say you use the term 100%. I don't know if you said certainty or 100% confidence, but mental health is one of the most complex subject areas in medicine. So to say one has 100% confidence, I'm not sure I would ever say 100% confidence, right? I mean, the point here that I'm trying to get at is, look, we have a request for $13.9 billion for 2023 for suicide prevention, up $1.5 billion. The VA budget has been growing enormously over the last 5 years in particular. I have a duty to try to figure out how those dollars are being spent. And I like to see, obviously, from 18 to 20, we saw a decline in the daily suicide rate, but data matters. So that's all I'm trying to get at is I just want to try to seek some more clarity, not just today, but going forward on how we look at this data and how we're accounting for it, because I have a lot of veterans in the district I represent outside of San Antonio in Central Texas, and I talk to them on a regular basis, and there's a lot of frustrations about their ability to get in and get care. And I heard data about the less than 20-second call times and 96%, 98%, all those things you have to study. But there's a lot of concerns about people have to. I have a veteran that I just talked to yesterday on a separate panel off the Hill who was talking about it's taking 90 days to get to the place of even getting an appointment to get care for a herniated disc. Now, he was able to deal with it in the private sector, and he's got a family around him. He's able to deal. But there's a lot of veterans that are hitting that wall, and they got massive pain, massive issues, and they're hitting a wall because of other obstacles, because of getting through the door in the VA, and then dealing with complicated technologies and complicated health records, not being able to go out and get community care easily, that then compounds itself. And then when you add substance abuse on top of that, it's a problem. Now, so I'll be seeking more information along these lines just so we can kind of understand it better and how we're using the dollar. Now, yield back because my time is up.
Thank you, Mr. Roy. I now recognize the gentlewoman from Illinois, Ms. Underwood, for 5 minutes. I guess Ms. Underwood is not on the virtual platform. I move to Mr. Trone for 5 minutes. Mr. Trone, are you on? Mr. Allred? All right, then we'll go to Mr. Mann for 5 minutes then. Mr. Mann?
Great. Thank you, Mr. Chairman, and thank you all for being here to testify this morning. Dr. Campbell, has there been any research done on the impact, if any, of employment on suicide prevention? When VA is analyzing veteran suicide data, does VA consider what non-VHA benefits and services veterans who die by suicide were utilizing?
Thank you, sir, for that question. Dr. Miller?
Absolutely. We know that employment and financial stability versus financial stability are important protective and risk factors. We know that attending to financial literacy is an important intervention that can be engaged at the prevention level. And that's why this year we have started the National Veteran Center for Financial Empowerment. Dr. Brenner is overseeing the implementation of that new center. And Dr. Brenner, I defer to you for a word or two on that matter.
Thank you. I'm so happy that you asked this question, and I think we need to find creative ways like helping people become financially literate to ensure that they are protected from suicide. So this new center will help us create an interactive mobile application, a website for veterans, a SharePoint site and training materials and consultation for VA clinicians to really understand the importance of financial empowerment. And then we will coordinate and make sure that all of our clinicians really are aware of this risk factor and are implementing by teaching veterans new strategies.
Great. Next question, again for you, Dr. Campbell. Your testimony states that video telehealth is, quote, a core strategy for increasing access to mental health care, end quote, in VA. How do utilization, adherence, and outcomes compare for telehealth mental health care appointments and in-person mental health care appointments?
Thank you, sir. Excellent question. And so during the pandemic, as you know, we were able to easily roll out telemental health, very critical as we were keeping people as safe as we could with the pandemic. And now at this stage, we are seeing that especially our younger veterans like tele, we can V-tel right into the office. I have clinic Tuesday morning, and my patient is competitively employed, and so he's able to find a quiet space. The research is indicating that the quality of telehealth is just as good as the quality of face-to-face. And so as we level out the pandemic, we are seeing more veterans wanting to come in for face-to-face, but we are also learning that telemental health is going to be the future in terms of convenience.
And do we have data yet on the impact of mental health services versus non-telehealth mental services, specifically impact on suicide rates? Do we know that at this time, or is it too early for that?
I will defer to Dr. Miller.
As you know, a core component of Suicide Prevention 2.0 is the implementation of a clinical program that offers 4 evidence-based treatments through telehealth to veterans at high risk for suicide. This will give us an excellent opportunity to collect data such as that you are speaking to. Thus far, we have implemented across 18 VISNs and 129 medical centers, and we've received almost 4,700 consults. That will provide a good basis for us to be able to address those good questions.
Great. Thank you, and with that, Mr. Chairman, I yield back.
Thank you, Mr. Mann. The gentleman from Maryland, Mr. Trone, is recognized for 5 minutes.
Thank you, Mr. Chairman. To Kyle and Ranking Member Boss for holding this hearing. As I mentioned last year, we really appreciate you taking the time to work on mental health conditions for our vets. To our witnesses today, thanks for joining us to answer these questions and update on your efforts on veteran suicide and the VA's master plan, SP 2.0. Dr. Campbell, my district is both rural and urban. Can you talk about how local strategies are formulated and how the VA would address the needs of a community like very rural Cumberland, Maryland, but more urban in a larger community like Frederick, Maryland?
Thank you, sir, for that question. We are able to leverage our telehealth services so that we have broader access for our veterans in those rural areas. And again, access is dynamic depending on the services that are required. We want to make sure that the patient has the right treatment at the right time. And so it certainly depends on whether that category of treatment is emergent, which we see veterans same day for that, as you know, urgent or more sustained treatment.
So I think that's great that you're working on personalizing the needs, the different communities. Thank you for that. To better understand the current state of telemental health, you guys are experts at this. You've been doing it since 2003. And we saw this massive spike with COVID on telemental health. What's happened now that COVID is beginning to slide into the background? Are people staying with telemental, or do we see a shift back into in-person?
Thank you, sir, for that question. We are seeing a shift in veterans wanting to come in for face-to-face, but we are also seeing veterans, especially those veterans who are competitively employed, and those veterans in our rural areas who prefer telemental health. And so we do think that telemental health is going to be the way of the future.
Boy, I'm with you completely. What do you think about percentages of the whole group of veterans? Do you have a ballpark percentage of how many are now on telemental health versus coming in person?
We are at about 52% veterans wanting telehealth at this point. During the pandemic, we were 29% in terms of face-to-face, and the rest were telehealth.
And what's the improvement on people showing up for their appointments? That's the biggest thing we've seen, out in the field. The telemental was much better for them to show up for their appointments. What are you seeing there?
Yes, sir. So we don't have to worry about the transportation piece, getting caught in traffic, then trying to find a parking space once you get to the local facility. And so, as I mentioned with my patient on Tuesday, he was able to get into a private office, and we started our appointment right on time.
It's perfect. You've talked about suicide and outcomes a little bit. Do you see any difference at all data-wise in the outcomes on a little bit lesser things, anxiety, depression, when we do telemental versus regular in-person?
And so the quality, thank you again for that question. The quality of telehealth we are finding is equal to the quality of treatment face-to-face. We're not seeing a difference in that.
I'm also on the Appropriations Committee and a strong supporter of veterans and Chairman Takano's efforts in this area, and especially in mental health area and addiction. Is there anything what's the future of telemental health for vets, and what resources or flexibilities and authorities should we be looking at, if any, in the appropriations cycle when we start 24 appropriations after the first of the year?
Thank you, sir. VA is putting forth a legislative proposal as it pertains to the prescription of controlled substances. So we know that individual states want to go back to the pre-pandemic way, and that patients are expected to come in for a face-to-face for medical evaluation. And we are needing legislation that will help us continue to provide the services without that stipulation, so that we don't have a gap in access and treatment to our veterans.
That's fantastic. You've got great leadership there with Secretary McDonough. and it's always a pleasure. Thank you for all the work you're doing.
Thank you.
I yield back.
Thank you, Mr. Trone. I recognize General Bergman for 5 minutes.
Thank you, Mr. Chairman. Let's get right to the point very quickly because time is of the essence. Dr. Campbell, would you please respond to the allegations made by America's Warrior Partnership through their Operation Deep Dive that VA's annual suicide prevention reports undercount veteran suicide deaths significantly? Do you agree with that assessment? Or if so, why? And if not, why not?
Thank you, sir, for that very important question. And no, I do not agree with that report. There are 5 areas that we know that our report differs. Again, our report is evidence-based scientific rigor, and I will defer to Dr. Miller for more specifics on that.
Concur on the non-agreement with AWP's report. I think it's important to understand apples versus oranges, and their report offers an apple versus orange comparison. First, they take a look at former service members versus veteran, and the definition of former service member is not comprehensively presented within their report nor matched to the data. Our definition of veteran and where it comes from is specifically mentioned in our report and in our methodology section.
I tell you what, I know you could go longer on this. I would, if it's possible, or maybe it's already been done on your side, is to take on one side the elements of their report, and then if you will, counter to that or support of that, and just lay it out in very simple format for us to see, because we're all, I think, just looking for truth and accuracy on both sides. And sometimes that is, Solomon had the biggest challenge. Okay, we could learn a lot by thinking about things in terms of the way he did in discerning truth from untruth. But it'd be helpful just to see what's being presented and what you have in very simple terms that the non-practitioner could discern from. Dr. Campbell, due to the nature of the DoD community, it is easier to compile suicide-related data, and reports do not face the 2-year time lag experienced when compiling veteran data. And I think that's kind of amplified by the fact that DoD may or may not have good access to IRR, individual ready reserve data, which is under DoD and yet not under VA. Do you use any of the DoD analytics to predict emerging trends or areas of concern?
Dr. Miller can respond, and thank you for that question.
Okay.
Thanks. The unique aspect of the DoD reporting is that they are able to have an internal system of medical examiners, coroner reports on their service members that allows them immediate access to death certificate type information for service members. That differs from us as it goes through the states, from the states to the CDC, and then through the databases. Are we able to use that for surveillance regarding trends and patterns? Yes, we are. For example, we're able to see if the DoD rate is going up in 2021 where we don't have 2021 data available to us yet.
I'm very appreciative of the dialogue here in your answer, because is there something, and I'm kind of thinking rhetorically here, is there something that we as the Veterans Affairs Committee can do to significantly decrease or eliminate that lag time of access to the data that DoD has when a life is ended, if you will, unnecessarily, and VA's access to it, so that you're getting like data and can do compare and contrast when it comes to treatments and therapies. Let's move on. Okay. Dr. Campbell, and it's okay. I really appreciate someone who says, I'm going to let so-and-so answer the question, because you're obviously referring to the people who are, deep in it. Can you comment on what, if any, work VA is doing to adopt a post-traumatic growth approach to veteran Mental health?
I will defer to Dr. Miller. He's shaking his head.
Absolutely, and Lisa, if you want to jump in real quickly, but post-traumatic growth is an important way of conceptualizing the potential with regard to experiencing trauma and working through trauma.
Tell you what, yeah, I don't want to overdo my time, but the answer is you're working on it.
That's a good answer.
Okay, thank you. Mr. Chairman, I yield back.
Thank you, General Bergman. I recognize myself for 5 minutes. Further reducing the unacceptably high rate of suicide among those who served our country is among the most urgent priorities facing our committee. One critical upstream step that we can take is removing financial barriers that might prevent veterans from seeking necessary mental health care. Currently, veterans receiving care through VA can be charged out-of-pocket costs for preventive services, including mental health screenings, even though almost all private health plans are required to provide coverage of preventive services without cost sharing. To right this wrong, I introduced the Bipartisan Veterans Preventive Health Coverage Fairness Act, which has support from VA and leading VSOs. My bill would eliminate all out-of-pocket costs for veterans seeking the preventive services they need and deserve, such as preventive interventions for perinatal depression. In my state of Illinois, maternal mental health conditions and substance use disorders are the leading cause of pregnancy-related deaths, yet VA is charging some veterans $50 per visit for perinatal depression services. By imposing this cost barrier, VA might be deterring some pregnant veterans or new moms from seeking the mental health care they need. I'm grateful for VA's support on my Veterans Preventive Health Coverage Fairness Act, which would remove these out-of-pocket costs. Dr. Campbell, can you tell us more about why it's so important to eliminate cost barriers that might prevent veterans from accessing preventive services for mental health conditions like screenings for depression?
Thank you, Representative Underwood, for that wonderful question, and we certainly appreciate your forward move on this piece of legislation. We learned from our annual report that financial stress is one area that increases the risk to our veterans. And so any way we can take away any barrier so that we can touch that veteran wherever that veteran needs to be touched, we appreciate and we collaborate with you on that.
Yes,
Thank
ma'am.
you.
Thank you. To reduce suicide among veterans, we need to advance evidence-based interventions like lethal means safety training requirements to ensure VA staff and others caring for veterans are prepared to have conversations with veterans about the intentional, voluntary practice of reducing suicide risk by limiting access to lethal means like firearms, medications, and sharp instruments. The requirements implemented during the Trump administration have led to 97% of clinicians, VHA clinicians, completing the department's training, yet VA's ongoing refusal to expand the training requirement has led to a fraction of 1% of all other VA staff, community care providers, and caregivers completing the training. That means that if you're a veteran interacting with a healthcare professional outside the VHA facility or with someone in VA who's not a clinician, it's highly unlikely that they've been trained in this evidence-based suicide prevention principle. Secretary McDonough has the authority himself to expand the department's lethal means safety training requirement right now, and I continue to call on the VA to do so immediately. I also look forward to working with Chairman Takano and my colleagues in our committee to advance the Lethal Means Safety Training Act, which would expand VA's training to all VA's employees who regularly interact with veterans in their work, plus community care providers and family caregivers. Today's hearing is about capitalizing on what works to prevent veteran suicide, and the evidence is clear. Lethal Means Safety Training works, and it's time to expand this training requirement and save veteran lives. Thanks, and I yield back. I am happy to yield now to Mr. Banks for 5 minutes.
Thank you, Madam Chair. Dr. Campbell, I'm wondering if have there been any studies that specifically look at the outcomes of the pandemic on veterans? Specifically, by what I mean by that, influencing the suicide rates, the inability to access care, social isolation, or unemployment. What studies are you aware of that the VA has conducted that specifically look into those factors?
So thank you, sir, for that question. As I mentioned in my opening remarks, we did very well in terms of suicide prevention in spite of COVID-19. And I will yield to Dr. Brenner to offer any further specifics on that.
Thank you for that question. I think what we are doing is watching and trying to plan ahead. We do know that there are predictors of suicide that have been identified amongst veterans during COVID, like food insecurity, also unemployment, as you mentioned. And what we do know from previous literature and previous pandemics in other countries is that sometimes suicide risk and rates of suicide increase after a pandemic. So I think what we're trying to do is make sure that we are there in the ready and that we can continue to kind of provide the care to ensure that the rates stay where they are.
So I guess my question, though, specifically, has the VA conducted any study at all about veteran suicides that take into account factors that are a result of the pandemic, like inability to access care, social isolation, and unemployment? And if there hasn't been a study since the pandemic related to veteran suicides, would the VA be willing to conduct a study as such?
We are certainly engaged in studies, and as I did mention, we did look at the impact of COVID on food insecurity and suicide risk. And I know that there's ongoing efforts. I will pass to Dr. Miller, too. I know that this is an ongoing of interest in terms of the annual report.
There have been studies that have taken a look in a methodologically sound way what's going on with veterans from a mental health perspective during this time. We would be happy to assemble those studies, summarize them, and present them to this body if that would be helpful.
I think it would be very helpful. And as veteran suicide rates were high before the pandemic, certainly these factors we can speculate, but a study would help us immensely to determine if some of the outcomes of the pandemic further influence veteran suicide. And I would think all of you would agree with that. You're talking about the effect of food insecurity, but factors like the inability to access care, social isolation, and unemployment seem like factors that we should investigate any further. I guess my question, though, Dr. Campbell, is there a reason why that data set hasn't been included? I mean, you keep referencing food insecurity, but why are those data sets not a priority for the VA?
Thank you for that question, sir. And I wouldn't say it's not a priority for the VA. Certainly it is. We can take that back for the record and get back with you. Dr. Miller may have an additional comment about this.
It may be helpful, Representative Banks, also to take a look at the annual report that was just released. I know it's a lot to get through, but as there's a section that talks about COVID and signals that we have available to us in VHA with regard to how veterans are doing. That section of the report offers what the signals are and what the current data is. What I can tell you in summary is that across the signals, there has been a decrease in suicide behaviors for VHA veterans compared to 2020 in 21 and in 22. So we are tracking that, but we also need to acknowledge those are signals, not the full picture.
We're also tracking data within a project called Ascend. This is amongst veterans in VA and not VA. We did measure rates of suicide during the COVID pandemic. About 9.6% of veterans reported suicidal ideation in the time during COVID and about 5% in the past month. We also asked veterans around risk factors related to the pandemic, and they did in fact say things like mental health, employment, and family stress did contribute to feelings of suicidal ideation. And also We also found that in particular, individuals who are caring for families and caregiver burden was a huge issue, particularly for the women in this study. The Ascend project is ongoing, and we will continue to collect this data over time. So I want to really reassure you that we are collecting this data in real time in veterans receiving VA care and non-VA care.
Thank you. My time has expired.
Thank you so much. I'm happy to yield 5 minutes to Ms. Lotkin.
Good morning, everybody. I apologize for being late. I had an overlapping armed services hearing, so I apologize if any of this is a repeat. But I'm particularly focused, we're discussing this week the Solid Start Act and reaching out to veterans 3 times in the first year of separation. I would say I have heard overwhelming feedback that the average veteran, at least in my state of Michigan, just doesn't know the full spectrum of services that they've earned, they're qualified for, from jobs to healthcare, the whole gamut. So we initiated this bill back in Veterans Day of 2020. We sort of announced it. Can you talk about that first year of separation? Obviously, my husband was in for 30 years as an Army officer. My stepdaughter is in now. I watched my husband in that first year, and when you've been in the Army your whole life and then suddenly you have to figure out a new plan, even for the most well-adjusted folks, it's a difficult period. What happens to suicide rates in that first year of separation?
Thank you for that question, and we know that's a very vulnerable time for our veterans, and Dr. Miller can respond more specifically.
First, suicide rates increase during that time. We know that. That's noted within.
By what? I mean, help put some meat on that bone.
It's noted within our annual report specifically that was released last week. But for example, I believe off the top of my head, the Army rate was 46 per 100,000 within that first 12-month period, and that was the highest rate. You compare that to the overall veteran rate, which was around 31.7, so you can see that it's significantly elevated. Yeah. We know beyond the generalities that there are specific subpopulations that represent even higher risk. An example of that would be those who are separating with less than 1 year in service, those who are younger than 20 years old, and those who are separating due to an administrative issue or separation. Solid Start covers everyone, and that's why we agree with you that it's an important service.
Mm-hmm. Let's say the program does its job. We pass this bill hopefully this week, and it's signed by the president. It passed unanimously through the Senate, so I'm hoping that it still has a chance to pass quietly through the House. We know that there's about 200,000 new veterans per year, right, who are newly minted veterans, and 18 million veterans total. If someone is going through that really terrible first year, that tough year, they've moved, they've got a lot going on, and we successfully get to them through these 3 attempts of telling them their full spectrum of their benefits, and they say, I'm not feeling myself and I need help. What can they expect when they walk into their average VA, let's say in Lansing, Michigan, in terms of suicide prevention?
So you're referring specifically to they have not engaged in eligibility, they said I don't need it, but yet they walk into...
No, someone gives them a call in their first year. They've just moved home to Lansing, Michigan. They are feeling unmoored. They don't know where to go in their life, and they get that reach out from the VA saying, here's everything you are eligible for, and they say, okay, well, let me at least try and step in there. What's the experience of the veteran who needs help at the average VA in this country?
Yes, so they should walk into the Lansing CBOC, and they should walk to the front desk, and if it's mental health, they say, I'd like to be seen by a mental health professional, please. That falls under our same-day access policy and procedures, and then the Lansing CBOC staff and personnel know to implement and kick in same-day access procedures, which will have that veteran receiving services accordingly.
So there will be someone to speak with them that day. We all know there's a shortage of mental health professionals. I thought that would apply to the VA as well.
There is a shortage, but according to policy, there will be someone to talk to them that day.
Okay, thank you. I yield back.
Thanks so much. I'm pleased to yield to Mr. Elzey. 5 minutes.
Thank you, Madam Chair. Thank you all for being here. You have a task that is almost insurmountable, and it affects, as I look around this room, everybody. We all know somebody who has taken their lives. We're left to deal with the pain when that happens, and we want to understand why in order to try to prevent it. And it seems like we're almost not getting anywhere. So you have a task that's almost insurmountable, and I appreciate what you do. From when a service member separates from the DOD and is picked up by the VA, there are gaps in that transition process. There is a seamless transition when a service member is separated from active duty when the separation is due to a medical discharge or a medical retirement. However, there's not a seamless transition for all other service members when they go from active duty to being a veteran. Every service member needs to have a seamless transition, including those who will have disability benefits delivered at discharge. We need to close the gaps in this transition, and I think it will help reduce veteran suicides. And so what I think we should be working on is the direct handoff between the DOD and the VA. Much of this responsibility should be up to the DOD. They do a great job of recruiting, training, sending off to war, and then they don't do a good job of training people to be out in the civilian world. There's your TAP class, here's 3 days. Good luck, Godspeed, we're all counting on you, and there's the VA over in the corner. They'll help you with what you need. So you have this mooring when you're in the military. You have this family when you're in the military. A lot of the kids, young men and women who join our military are from failed family backgrounds, so the military becomes that family. And then when we cut them loose, they don't have that family anymore. So to your point, the point about losing them in the first year is absolutely not surprising to me in any way, shape, or form. And we need to do a better job and force the DOD to do a better job of handing off to you. So when dealing with a non-medical separation, and I'm happy because we have limited time, if you need to answer this in written statement, I'm fine with that. But through the benefits delivery at the discharge process, do you have any other recommendations on closing the gaps in the transition from active duty to civilian life?
I will just make a few brief comments and then defer to Dr. Miller, but we are working with the Department of Defense to help close that gap. Dr. Miller and I are both veterans, and just the transition when you are just have less stressors is difficult, just not wearing the uniform again. And what do you do as a civilian? So we certainly understand that. Dr. Miller.
We agree with you 100%, and let me offer a few things that we're watching to close that gap and invite you to partner with us and watch as well. Number one is the implementation on the DOD side of the separation health assessment as part of Executive Order 13822. That is scheduled to kick in, I hope, in the near future, according to report, and that should help provide a better process of identification and care coordination. Number two, keep an eye on Hannon Act 101 implementation, and that has components that are designed to take what we did in 13822 and expand.
Okay, thank you. One of the Operation Deep Dive takeaways is that former Coast Guard members have the highest rate of suicide of any of the services, and I think, unfortunately, sometimes we fail to mention the Coast Guard as being a service. Do you have any reasoning, understanding of why they may have the highest rate of suicide?
Dr. Miller?
Thanks. I would need to look at that specific data and where that was drawn from, so I do not, without having that look, I'm hesitant to address that question specifically. It's an important question. I apologize.
That's okay. That's part of what we're trying to figure out here. I mean, special operators who have been at war for 20 years and then they're suddenly left adrift, they commit suicide. And so the Coast Guard issue is interesting to me. In our closing minutes, I just want to make sure, do we already have Solid Start at the VA?
Yes, Solid Start was part of Executive Order 13822 implementation. It's been in effect.
Is it going to sundown at any point?
There are no plans to sundown upon the Solid Start services. VBA is doing an excellent job of managing that program.
Okay. I'd like to point out that we take answers, Republican and Democrat, in order here in this committee hearing, but veteran suicide, this issue has no bias doesn't care what you look like, what party you lean towards. It's an affliction, it's a crisis. 22 a day, arguably more, that I commend you for being here. I commend you for what your job is. It's very personal to all of us in this room. Thank you for your testimony today. I yield back.
Thank you, Mr. Elzey. I now recognize Representative Allred for 5 minutes.
Well, thank you, Mr. Chairman. I want to thank our witnesses from the VA for being with us. I want to agree with my colleague, Mr. Elzey, from my neck of the woods in terms of our bipartisan agreement about doing everything we can to prevent veteran suicide. And Dr. Campbell, in your testimony, you highlighted VCL's peer support outreach call center program. I think there's something very powerful about giving veterans in recovery the opportunity to support other veterans, and that's why I co-led on the Veterans Peer Support Act that was included in the Strong Veterans Act that passed the House this year. This provision will expand the peer specialist program to all VA medical centers over the next 5 years. I was wondering if you could expand on the peer support outreach call center program and the feedback you've received on its success.
Thank you, sir, and we appreciate the question and certainly your support and collaboration on this. Dr. Miller.
Thank you. The Peer Support Outreach Center, I'm so glad that you brought that up. We have two phases of operation, if you will, in the Veterans Crisis Line. We have answering the call and we have beyond the call. Yes, it's critically important to answer the call in 9 seconds or less across 2,100 calls. But what we also know is critically important is what happens after the call. How do we follow up and help to care for those veterans? The Peer Support Outreach call center was developed in that spirit, in that motive, where veterans, peer support with lived experience, reach out to higher risk callers of the Veterans Crisis Line and offer them a connection. And in many ways, the conversation and the engagement is dictated by what the veteran caller needs, the questions that they have, and then ensuring that they're plugged into and receiving the support that they need. Thus far, feedback from both staff and from the veterans is overwhelmingly positive about the value of veterans talking to veterans in this area.
Well, I'm really glad to hear that. And I'm wondering, Dr. Miller, if you could just discuss how expanding that program to all VAs could increase our reach to all veterans. Do you see this as a program that would scale up?
We know, yes, is the short answer, and I'll tell you why. We know that one of the underlying factors that serves as an internal barrier for access to service for veterans is trust. And although we're making significant improvements and gains in trust in veterans, in VA and VHA, we also know that veterans trust other veterans, and when they're working with and partnered with veterans under VHA care, that's very powerful towards building that trust bridge.
Yeah, I certainly agree. At the Dallas VA or the Garland VA in my district, veterans, seeing other veterans in any context and knowing that so many of our VHA employees are veterans, I think is a great comfort, and I think this is a great program that I hope we can see expanded. I want to shift gears just a little bit, Dr. Brenner, and talk with you. Last year, I spoke about the use of alternative treatments, like MDMA, for example, as a potential treatment for PTSD and other suicide risk factors. Since then, research from the Harvard University Department of Psychology has found that the use of MDMA and, I hope I pronounced this right, psilocybin, is associated with reduced odds of suicidal thinking, planning, and overall psychological distress. Obviously, when it comes to preventing veteran suicide, we should, I think, be looking at all avenues of research, of new ways to try and treat. Is the VA tracking these studies? Are there any plans for the VA to conduct its own research into this area?
Thanks for asking the question and returning to this important topic. We, like you, want to be tracking everything that's happening out there, and we are watching very, very closely, both in terms of clinical care and research. At present, psychedelic treatments are not part of the standard of care, and that being said, VA researchers are engaged to be engaged in research around this. However, they need very specific safety and IRB approvals to ensure that we are keeping our veterans safe while we are exploring these new interventions. These current projects are not funded by Office of Research and Development, but VA is engaged and watching closely.
Are there any congressional approvals, for example, that you may need to conduct those studies, or is it more on the administrative side?
I will take that back for the record. Thank you.
Thank you. I yield back, Mr. Chairman.
Thank you, Mr. Allred. I recognize Mr. Rosendale for 5 minutes.
Thank you, Mr. Chair. Appreciate that. Dr. Campbell, your office has been tracking 10 critical problems with the Cerner electronic health record system, and I want to ask you about 2 of them specifically. Patient record flags, which alert providers to screen veterans for suicide risks and other mental health issues, do not exist in many of the Cerner modules, like radiology, emergency medicine, or dental, and they're inadequate in the administrative module. What impact has that caused?
Thank you for that very important question, Representative. And we are also deeply concerned about the challenges that we are experiencing with Cerner. And our most important concern, of course, is patient safety. And so in regards to the risk flag, we have been able to make sure that it's showing up for the provider to see. Where we still haven't resolved the issue has to do with the administrative piece that you mentioned. So since I have been in the position, I have a regular cadence with our executive leader operations person who champions Cerner to keep that person updated as soon as I find that there is an issue or a problem, especially where it concerns patient safety, as well as our mental health champion. And so you are correct, sir. There are still issues with this that we need to resolve.
There truly are, Dr. Campbell. My colleagues and I included this in a list of critical fixes that we asked the VA and Oracle to prioritize back in June. The status report we received 2 weeks ago characterized this as a new service request, meaning that Cerner had not been expected to provide previously. It also said Dr. Adirum's office approved moving forward in May, but there's no other dates indicated when VA or Oracle will take any action. When do we anticipate that these problems will be resolved?
So I am aware that the patient safety flag is #1 clinical priority in this space, and I will take that back for the record to get more specific information about when that will happen.
I appreciate it, because this goes directly to the patient safety reports that we continue to receive that trouble all of us on this committee.
Yes, sir. And I will add that a national patient safety team has been stood up now specifically for EHRM to take a look at these cases. So
in Spokane, a veteran's mental health care referral was lost. It was lost in Cerner's unknown queues and delayed. Thankfully, he called a veterans crisis line and a potential tragedy was averted. In this situation, the Cerner EHR clearly impeded VA in delivery timely care. How often is this happening, and what guidance is your office giving to mental health providers who are struggling with the EHR?
Thank you again for that question. So our mental health providers have developed mitigation strategies to track, again, these cases. And so that does put burden on our staff to do that, but we do all that we can to keep the patients as safe as we can during this transition.
And obviously, the mental health, the physical conditions that a lot of our veterans are experiencing obviously are a priority as well, and that time factor can allow things to progress and make them even worse. But in mental health conditions, we're talking about minutes can save lives. And it is critically important that we address this. Aside from the EHRM headaches, there's also the persistent issue with the wait times that we continue to hear for the VA. Yesterday, I participated in a forum in which we heard that the wait times and access to primary and specialty care can frequently be measured in months. I think everyone would agree that it would be unacceptable for mental health visits for suicidal ideation to take months to schedule. In your mind, are the ongoing wait time problems an obstacle to veterans seeking mental health treatment?
Thank you for that question. And so, of course, we are always looking at our access, which I mentioned is a very dynamic process. And so we look in terms of urgent, emergent, and sustained care. And so the access change can occur based on the type of treatment needed and the geographic area. And so for those veterans who have emergent needs, they are seen same day.
Mr. Chair, and if I could just ask one last question. Would it be better, Ms. Campbell, for veterans to access care sooner through a private provider of their choice rather than much later through a decision made by the VA or a referral from the VA?
So we meet the veteran where the veteran is. Certainly we prefer for that veteran to come to VA because we understand veterans. We train in the cultural competency of military, and we understand war trauma. And so as best we can, we want that veteran to come to us for treatment. We are able to leverage, as I mentioned earlier, our telehealth services across the country. And so our preference is for us to treat our veterans.
Thank you, Mr. Chair. I'll yield back.
Well, thank you. I just want to say, with respect to Mr. Rosendale's concern about Cerner's electronic health record issue and suicide risk flags, I'm in alignment. And we will, on the bipartisan basis, make sure that we get to the bottom of all of this, and we will put the veterans' safety and health and life first. With that, I will recognize Representative Miller Meeks of Iowa for 5 minutes.
Thank you, Chair Takano, and thank you to all of our witnesses. I'm a physician, but I'm also a 24-year military veteran, and I just wanted to comment on the last comment made. I would rather have veterans have care anywhere than not have care and commit suicide. And I think one of the challenges that certainly I face in my district, and we have an excellent VA hospital at Iowa City, is that there is often a reluctance and a delay in the VA allowing people to receive care within the community. We have excellent care that's with substance use disorder, mental health, suicide prevention, and that was the intent of the Mission Act, was that veterans receive care. So I just want to state that. And then I also want to reiterate something because the public often watches these hearings, and it's an oversight hearing, but I want to just reiterate something that Ranking Member Bost had said. We did a Veterans Roundtable in our district, my district, just a couple of weeks ago, and that when we listen to these hearings and we participate in them and we talk about veterans, we're trying to conduct oversight and also make sure veterans have the benefits and the resources that they need and to which they earned, not they're entitled, they earned. But with that, often the veteran is portrayed as someone broken, and we rarely talk about the vast number of veterans, by far the greatest majority, who lead productive lives, who are assets to their employer, assets to their community, do volunteer work. So I just wanted to state once again that the vast majority of veterans don't face these issues, and part of that is because of the care you gave. So just kind of in follow-up to my first statement about community care, Dr. Campbell, in their testimony, America's Warrior Partnership notes that the scope of the Fox grants was dramatically widened to include national and state-level programs. How many of the 80 grants awarded went to statewide or national programs? And how will you assess their effectiveness at the local level within the communities these grants are intended to target?
Thank you, Representative, for that great question, and I'll defer to Dr. Miller.
You are correct in terms of the scope. However, within that context, there needed to be direct links established at the local level, and then there needed to be outcomes that will be measured and produced at that local level. If applicants were not able to make the tie from a national or state level to a local level in a way that pre-post could be reasonably measured, they were not awarded a grant this year.
Okay, thank you for that. And then my next question is perhaps best geared to the next panel, but I've got another meeting that I have to participate in. And so, you know, within our district and our state, and we've done our veterans panel, and as a veteran, I meet with my veterans group. I'm part of both my VFW and American Legion. I've been really impressed with what the American Legion has done in introducing systems like the Buddy Check program. And this is a system to connect veterans that may not know who to ask or where to go when talking about their mental health. And this is extraordinarily important. As you mentioned, the VA hospital understands the military culture. Veterans understand other veterans. And the Buddy Check system has seen to be effective, as the American Legion has seen more than, nationwide, 234,000 veterans reached through this system. In our own area, we've seen suicide rate decline. And what's the VA doing to implement a similar system or ensure that veterans are getting the direct and immediate care and the, if you will, peer support from fellow veterans?
So thank you again for that great question. My colleagues and I, a couple of weeks ago, met with the National VSO leaders right here in Washington, D.C. American Legion was part of that. I am not aware of the specific Buddy Check that you're talking about, and I'll certainly ask my colleagues if they know more than I do.
I think, thank you for asking this. I think we've heard today already about peer support and buddy checks, and I think there's a lot of different names for veterans taking care of veterans. And I can give you one great example. In rural communities, we have a project called Together with Veterans, in which we are working with veterans to help them identify best ways to reach out to veterans in their own communities, to identify risk, to be there for each other, to teach each other about lethal means safety. And so I think there are many names for buddy checks, and I agree with you. This is so important in terms of overall suicide prevention.
Thank you so much. I yield back my time.
Thank you, Dr. Miller-Meeks. I just want to point out that Buddy Check is in the STRONG Act and bipartisan bill, and hopefully we can get that done by the end of the year. Is there anybody that wishes to go for a second round at all? Nothing? Does the ranking member mind if I just ask, just make one question of the panel before I dismiss it? Great pleasure that my Remove Co-Pays Act passed on a bipartisan vote in the House last night. I thank the ranking member for supporting that. Can you just briefly say, Ms. Campbell, what the impact will be if the Congress gets this bill done and gets to the President's desk?
So thank you, Chairman, for that question, and we really appreciate your support on this bill. We know that financial stressors, again, as was reported in the annual report, will place our veterans at risk, and we want to remove any barrier that may exist that's going to prevent the veterans from getting the care they've earned. So thank you.
Well, thank you very much, and I appreciate the bipartisan support that came out of this committee and on the floor of the House last night. It does strike me that no veteran should hesitate, nor should any veteran's friend or relative hesitate to call the 988 phone line and get a veteran to seek help. They should not hesitate because they think there's going to be a bill. They should not hesitate for their first 3 appointments in a year, nor should they hesitate if they have an emergency. They should be able to get into in or outpatient treatment forthwith. And again, I'm going to repeat that instruction that Ranking Member Bost also, I think, in a timely way, put in his opening comments. please, if you're having a mental health emergency, you're having a concern, please call 988 and press 1. All right, I'm going to, this completes the questioning of this panel, and I want to thank our VA witnesses for appearing today. And we'll now move on to our second panel. Doctors Campbell, Miller, and Brennan. You're welcome to stay and listen to the testimony of our second panel witnesses, which I think will be very important for VA to hear. But with that, I dismiss the first panel. I now would like to call up and recognize our second panel. Just over a week ago, VA announced the community organizations and state and tribal governments, which will receive the first round of suicide prevention funding through the Sergeant Parker Gordon Fox program. VA prioritized grant awards to organizations in geographic areas with limited healthcare access, rural communities, tribal lands, high populations of minority veterans, and areas with high per capita volume of calls to the Veterans Crisis Line. Each witness testifying on this panel represents one of these groups. And we know that suicide prevention is everyone's business, and that VA must partner with those who know their community of veterans the best in order to be successful. And with us today are Chief Chuck Hoskin Jr., Principal Chief of Cherokee Nation, Ms. Shauna Humphreys, Director of Behavioral Health for Choctaw Nation, Ms. Jenna Larson, Aleutian Pribilof Island Association, Mr. Michael Blecker, Executive Director of Swords to Plowshares, Ms. Wendy Clinton, CEO of Black Veterans for Social Justice, and Mr. Jim Lorraine, President and CEO of America's Warrior Partnership. I want to thank you all for being here, and we look forward to hearing from you. I'll remind you to pause for 2 to 3 seconds before speaking and answering questions. Chief Hoskin, we are so very honored to have you here with us today. We know that Native veterans serve in the United States military in disproportionate high numbers, but also die by suicide at disproportionate rates. I was really pleased to see that you were successful in getting this new grant to tailor suicide prevention approaches for Cherokee Nation's veterans. You are recognized for 5 minutes to present your testimony. Chief Hoskins.
Chairman Takano, Ranking Member Bost, and distinguished members of the committee, I want to thank you for including Cherokee Nation as part of this important discussion. It's my privilege to serve as Chief of the Cherokee Nation, the largest tribe in the country. We have more than 437,000 citizens. We, in fact, have Cherokee citizens in all 50 states. Of course, our reservation is located in northeast Oklahoma. As you have noted, many Cherokees have served bravely in military service to the United States. In fact, in disproportionate numbers, Native Americans have served. That, of course, includes Cherokee veterans who have demonstrated a deep commitment to this country. That is the reason that we pay respect to our veterans at all of our public events, and we recognize those who fought battles, who served, and who gave all for our freedoms. We are doing more than ever at the Cherokee Nation to ensure that veterans receive the services that they deserve. Earlier this year, each year, I should say, our Office of Veterans Affairs links thousands of veterans, not only Cherokee veterans, but all of the veterans in our communities that come forward for services or to whom we do outreach to connect them with services. We connect them with Veterans Administration resources. We provide them with as much care as we can provide. Most often, we are connecting them again with resources in the community, including the Veterans Administration. There's much more that we could do for our veterans, particularly in the area of mental health. And as has been noted extensively at this hearing and in your introductory remarks for my testimony, suicide is a problem. It has long been a problem among the Native American population, and a veteran living in Oklahoma is twice as likely to commit suicide than a non-veteran. And as you've noted, the suicide rate for Native veterans is high. It has in fact doubled over the last 15 years. Native Americans consider suicide, Native veterans consider suicide at a rate higher than any other ethnic group. And as Chief of the Cherokee Nation, that is a jarring statistic. Over the past 3 years, more than 80% of veterans served by Cherokee Nation's Behavioral Health Department have had suicidal thoughts. So now more than ever, it's critical that our veterans have ready access to mental health services and social services. As you noted, we have been awarded a significant resource under the Fox grant program, $750,000 to help launch Cherokee Nation Veteran Suicide Prevention Program. Now, this program will effectively, efficiently, and sustainably implement suicide prevention across the Cherokee Nation reservation, specifically for veterans and their families. It will address service gaps, transform how veterans at risk of suicide are viewed and cared for. Specifically, we'll implement a process for veteran suicide screening, a surveillance system of individuals who screen positive for suicide, an evidence-based therapeutic framework for addressing suicidal behaviors. This multi-level approach will allow us to better identify and monitor those at risk and provide them better care. The effort marks a new approach to the work we're doing to address suicide in Northeast Oklahoma among the veteran population. It will reside within our Office of Veterans Affairs, but we will work between that office and our health services, which include a Department of Behavioral Health. It will be holistic in nature. Quite simply, if a veteran asks for help, we'll be able to assist them in any possible manner. All of the staff involved will be trained on evidence-based approaches to engagement with veterans and those at risk of suicide, including motivational interviewing and suicide brief intervention best practices. Our professionals will work as a team to meet the individual needs of every veteran that comes in the door. And I want to stress every veteran. We interact with veterans from all walks of life. Over time, we expect this program will provide suicide prevention and referral services to approximately 400 clients per year. Mr. Chairman, members of the committee, I want to thank you so much on behalf of the Cherokee Nation for this opportunity to speak out on this important topic. Waddell.
Thank you, Chief Hoskin. Ms. Humphreys, we are happy to have you with us for the first time testifying before Congress. I'm eager to hear about the work that you've been doing in the state of Oklahoma for Choctaw veterans and how the great new VA grant will allow you to amplify those prevention and intervention services that you are innovating. I recognize you for 5 minutes to present your testimony.
Holly Toad, Chairman Takano, Ranking Member Bost, and distinguished members of the Veterans Affairs Committee. Thank you for holding this hearing and the opportunity to provide testimony. Preventing veteran suicide and meeting the mental health needs of our veterans are top priorities for the Choctaw Nation of Oklahoma. As you said, I'm Shauna Humphreys. I'm the Behavioral Health Director for Choctaw Nation. Chief Gary Batten and Assistant Chief Jack Austin Jr. asked me to speak today on behalf of Choctaw Nation to share information about what our nation is doing in regards to mental health services. Our Choctaw Nation Behavioral Health Services are housed within our Choctaw Nation Health Administration. We have behavioral health staff located in 7 out of 9 outlying clinics and at the flagship hospital that span across our 11,000 square mile Choctaw Nation reservation. We serve Choctaw tribal members as well as members of federally recognized tribes that are located on our rural reservation. I became a counselor because I wanted to help people, and I feel privileged to serve my fellow tribal members. My family also has a history of military service, including a great-grandfather who served in World War I. He's buried in France because he gave all for our country. So it's my honor and privilege to serve those who have served our country, and I'm honored to be here with you today and discuss this matter of grave importance, which is suicide prevention among our veteran population. As Chief Hoskins said, suicide rates among our veterans remain at an all-time high, and that is especially true in tribal communities. It's higher in Native American communities more so than any other group in the United States. On the Choctaw Nation Reservation, suicide rates are about 23.9 per 100,000 on an annual basis, placing us within the highest rate in the country. But despite these disparities, we have made great strides in addressing suicide within our communities. One way is by increasing access to behavioral health care by incorporating assessments into every visit. We have integrated counselors to discuss with patients the options they have for mental health services while they're in one of our facilities being seen by our primary care providers. These assessments and screenings occur during just a regular doctor's visit and really help us identify people who otherwise may never seek mental health services on their own. We've also added 4 employee health counselors to address the mental health needs of all employees and include mental health awareness training as part of our new hire orientation. Our approach also involves case managers to ensure well-rounded quality of care. Recently, we had approximately 300 unduplicated patients benefit from the coordination of care, and nearly 1,600 calls were completed to arrange appointments, connect patients to services, and provide resources for well-being. Due to there being a high risk of suicide within discharge from an inpatient stay, we have assigned case managers fully funded by the nation to be on the discharge planning for every patient that we sent to receive these services outside of our facilities. 230 patients were discharged and made a follow-up appointment to see Choctaw Nation counselor, and of those, 72% attended their appointment. I feel like this is a huge step in the right direction to serve our patients during critical times of need. We are thrilled to add services that specifically address veterans' needs. The Choctaw Nation received the support of the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant from the U.S. Department of Veterans Affairs. This will allow our team to work across programs within the Choctaw Nation to specifically address and prevent suicide among our tribal veterans. We will serve 200 veterans and their families through this program. With this funding, the nation will hire 1 counselor and 2 peer recovery support specialists. This will provide jobs to people who are living in recovery and can share their experiences to help and support others in similar situations. We will provide innovative services to our veterans, such as general suicide prevention, lethal means safety, expanded telehealth services, group sessions, animal-assisted therapy, outdoor recreational therapy, and incorporate Choctaw cultural activities as prevention. Group services for veterans' families will be established to educate and inform the family members on what to do and say in serious situations. We want to empower families to help their loved ones and save lives within our community. We believe mental wellness has a ripple effect. If one individual is helped, it leads to a healthier person, to healthier families, healthier communities, and ultimately a healthier Choctaw Nation. We are thankful for this grant and the partnership with the VA to positively impact the lives of our Choctaw veterans and their families. We want this to save lives and provide hope on our reservation. Thank you for the opportunity today to share information and for your commitment to suicide prevention. I'll be pleased to answer any questions if you have any about our suicide prevention efforts or serving our veterans. Yakoke.
Well, thank you, Ms. Humphreys. Ms. Larson, I understand that you too are testifying before Congress for the very first time today. And we are thrilled to have you with us all the way from Anchorage, Alaska, presenting on behalf of the Aleutian Pribilof Island Association. I recognize you for 5 minutes to present your testimony.
Good morning, Mr. Chairman, VA representatives, and my fellow tribal representatives and esteemed people of the House. The Aleutian Pribilof Islands Association is a federally recognized tribal organization of the Ali Unangaf people of Alaska. A 13 board member of directors governs our association. APIA was chartered in 1976 as a nonprofit, and we contract with federal, state, and local governments and receive private funding so that we can give the Unangak people in our region services like healthcare, education, social programs, psychological interventions and support, employment and vocational training, and we offer public safety services as well. We are humbled and honored to be awarded the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant. This award enables the VA to provide resources towards community-based suicide prevention efforts to meet the needs of veterans and their families through outreach, suicide prevention services, and connection to VA and community resources, in alignment with VA's national strategy for preventing veteran suicide. This grant program assists in further implementing a public health approach that blends community-based prevention with evidence-based clinical strategies through community efforts. This objective of the SSG Fox project coincides with the mission of APIA to strengthen and preserve Unangak cultural heritage and utilizing culture as a form of prevention. We use SAMHSA's evidence and practice-based gatherings of Alaska Natives, otherwise known as the Gathering of Native Americans in the lower contiguous states, as a model and have adapted it to specifically fit our region. We call it the Alaska Native Cultural Health and Resilience, or ANCHOR gathering. The geographic area of proposed service will be our existing health department communities consisting of Atka, Nikolsky, Unalaska, King Cove, which also includes our Belkowski tribal members, and St. George, Alaska. A population of focus for our project that we have called Funding Our Angach, Unangach, Learning the Wisdom of Our Ancestors, is service members and veterans and their families comprised of Unangach tribal members. It's important to note here that Angach is the Unangach word for breath. And after the happenings of the past few years, it's important and more important than ever for all of us to be able to breathe. With this project, we will hold a yearly anchor gathering in Unalaska each year of the grant life, as well as hold quarterly educational trainings in alternating remote communities and monthly educational trainings in Anchorage. We'll establish peer support services that will aid in suicide prevention and assistance in obtaining VA and other emergent needs, and provide non-traditional and innovative approaches and treatments. Healing doesn't happen in a vacuum. We need each other. We need connection. And these gatherings that we are having are empirically substantiated to accomplish the suicide prevention that we seek. To quote Dr. Gary Ferguson from our region, culture is truly medicine when it comes to mind, body, and spiritual well-being. Powerful transformation can take place as we reconnect to our roots. The traditions, values, and stories from our ancestors create a terrain for intergenerational healing. The challenges in working in behavioral health in Native country, especially for our Native veterans, is the effectuality gap between the Western model of service delivery, which is an extension of Western colonization, and Indigenous methods of treatment. Our program stands to bridge that gap. It's important that we offer all that we do and strive for more wide-reaching suicide prevention modalities because American Indigenous peoples have a higher rate of suicide per capita than any other demographic. Over half of our Alaska Native population deaths are due to suicide. Veteran rate of suicide is considerably higher than the general population. Previously, the stats were 1 in 5 suicides was a veteran. Compounding the veteran suicide rates with the Alaska Native suicide rates, it's staggering, but it's a preventable reality. Our Aleutian Pribilof region has the highest per capita veteran population in the state. In the Unangach culture, when we focus on strengthening the community, everyone benefits. And we want our veterans to be served in our traditional ways so that they feel truly supported and valued as the honorable warriors they are. This is where the mission of the Aleutian Pribilof Islands Association and the purpose of this award coincide perfectly, as prevention on tribal lands is one of the priorities of the Staff Sergeant Gordon Fox Suicide Prevention Grant Program. And we are poised and ready for this sacred life-saving work. So thank you for making it possible.
Well, thank you very much, Ms. Larson. I just want to say, before I move on to our next witness, that Chief Hoskin, Ms. Humphreys, and Ms. Larson, I was very moved by the testimony from our Native and Indigenous peoples who have given so much to this country. And I'll be so interested through our questioning period to learn more about how you're able to deliver very, very specific outreach and care. With that, I will call on Mr. Blecker. I recognize Mr. I thank Ms. Larson, but Mr. Blecker, I know that my staff has called on your expertise for many years and that the work of Swords to Plowshares reaches far beyond supporting veterans in need of housing security. I have directed this committee to take a multi-pronged public health approach to veteran suicide prevention, and I'm eager to hear how you will use new grant funding. And I'm pleased to now recognize you for 5 minutes for your testimony.
Thank you. Good morning, and thank you, Chairman Takano. I really appreciate it. We're very honored. First of all, my name is Michael Blecker. Again, I'm a Vietnam combat veteran, and I have been the director of Swords for over 40 years. And we're very grateful for the recent award for Staff Sergeant Fox Suicide Prevention Program. We were notified last week of our selection to participate in that critical program that will bring mental health services to the community-based level. It's so crucial. So SUARTS provides care to nearly 3,000 vulnerable veterans. These vast majority have incomes below the federal poverty line. They're at grave risk of being homeless. They come to us with complex medical care needs. And we attempt to do our best job to serve them. We provide counseling, employment, legal services for vets to access VA care. And we also do a lot of supportive housing and housing interventions. We actually provide permanent supportive housing for approximately 500 formerly homeless veterans in San Francisco. We can't really have a dialogue about veteran suicide without talking about the veterans who are most underserved. These veterans who are marginalized or poor, aging, often cast aside by our own rules and regulations that systematically deny them access to the resources they need to rebuild their lives after service. Take, for example, the formerly homeless vets who live with us in permanent supportive housing. Most are seniors, all have at least one disability, and all are without housing, some for decades. These are vets who are in despair. And in many cases, they just need that connection, the human connection to make a difference. A couple key points, some data. The highest number of veterans who die by suicide are between 55 and 74 years of age. Veterans who have experienced homelessness are almost 8 times more likely to have attempted suicide and twice as likely to have completed suicide. Other non-honorably discharged vets are twice as likely to complete suicide. Veterans who identified as LGBTQ are more than twice as likely to die by suicide. Suicide prevention happens in places where vets are seeking care, community, camaraderie, and accessible services. And suicide prevention is not defined by clinical licensure or medical models. Vets need to feel welcome, regardless of their military discharge status, eligibility, or personal identity. We hire folks with lived experience, and we make sure that they can provide the care they need. We bring the perspective of embedding suicide prevention in wraparound care to address social determinants of health, including housing, access to healthcare benefits and income, community connection, and peer support. The pandemic brought the shortage of mental health professionals to a crisis level, and we need innovative solutions. We're grateful that the Sergeant Fox program can foster innovation, but innovation does not serve vets if programs are temporary. The program comes to an end in 3 years' time. That is inadequate. Ongoing sustainable funding is needed. While we all bear the responsibility to assist veterans, Congress bears the final responsibility to fund veteran services. We need to make meaningful investments in the community-based organizations that are already doing this work to prevent suicide among our vets. Let's not go deeper, let's not go wider, let's go deeper. I mean that by saying some of the instrumental programs that the VA authorized brought lots of numbers of veterans off the street, but they're currently at risk. They need a lot of contact. They need a lot of connection. And that's where we're excited that this grant will allow us to provide that comprehensive level of care for those who are formerly homeless. Today, I call upon Congress to examine the viability of a permanent community-based mental health program that addresses veteran suicide, prioritizes the mental health supports our most vulnerable veterans need, and complements VA's effective homeless programs. Thank you very much.
Thank you, Mr. Blecker. Ms. Clinton, I understand this is your first time testifying before Congress, and I welcome you to the House Veterans Affairs Committee. As an Army veteran and CEO of Black Veterans for Social Justice, your voice and your organization's work are so important in this space. And I invite you now to present to us how your organization will continue to advance veteran suicide prevention with the new grant. I recognize you for 5 minutes.
Greetings, Congressman Tanaka, and everyone here on this call in your respective places. Black Veterans for Social Justice is honored to make this presentation to you as a first round awardee of the VA Sergeant Fox Suicide Prevention Grant for Veterans. I would like to introduce myself, our organization, and provide a brief outline of expected services. Again, my name is Wendy McClinton, the President and CEO of Black Veterans for Social Justice. I have operated BVSJ for 12 years and have been with the organization for 28 years. I am honorably discharged from the United States Army, a PTSD and MST service-connected veteran, and the mother of 3 children who was homeless shortly after leaving the military, so I know of what I speak. Thankfully, due to the founder, Joe Mashariki, I was offered an opportunity within his organization to create opportunities for veterans and have been with BVSJ ever since. It's been challenging and an honor to serve my country and those who protect its freedoms when they become home. We believe BVSJ is an excellent choice due to our commitment to veterans and our many years of serving with veterans suffering through poverty and mental illness. But what we do best is listen with tender, loving care and a listening ear. That is critical because we understand veterans' backgrounds and the lives and the communities they return to live. As peer mediators, we can see how they feel and hear their problems. In response, we can guide them through services they need to resolve their current issues and mitigate trauma while creating a service plan that moves them toward independent living. This typically includes housing, employment, food, and respite. There will be ongoing sense of community via a regular meeting of BVSJ's Veterans Advisory Group. The BVSJ program will cover the New York City metropolitan area. We expect to be in discussion with the VA on how to best implement our grant as not to duplicate services. But the main, we expect to talk to about 1,000 per year via a hotline and outreach, and expect to provide case management for about 220 utilizing case management plan and referral services. For the most difficult cases where a referral is not enough, we will enlist the assistance of the VA and our community partner, the Family Center. We expect them to conduct substance abuse, mental health, and co-occurring disorder counseling in tandem with community and veteran support we develop within the community. In all cases, veterans will have suicide and safety prevention plans to guide their recovery and as resources when they are navigating life by themselves. We hope to capture even more immediate care tools via a telephone application. There will be 4 main goals. The first goal, get up to 800 calls per year from the hotline and public information campaigns. The second, participate in 2 public outreach events per week to elicit support and get at least 2 program referrals per week. Enroll 220 veterans in suicide prevention case management, make referrals to the VA or the Family Center for Behavioral Health, Substance Abuse Disorders, and co-occurring conditions. Help 40% of the enrollees improve their functioning and suicide risk levels as indicated by several professional analytical tools and lifestyle improvements. All of this work will be led by a master's level trained and experienced director, a senior case manager, a clinical team with a professional mental health agency currently working with the VA via a SAMHSA grant, 5 case managers, a housing employment specialist, and an accountant. Please understand that most veterans we help will not commit suicide, and there will be many false positives. But the work we do every day is part of the VA's public health solution so that more isolated veterans can come into light, utilizing the services we have operated for over 40 years. We know that we cannot solve this problem alone, and we appreciate the opportunity your committee, the VA, our community partners, and veteran colleagues have provided us to make this happen. Thank you so much for this great opportunity.
Thank you so much, Ms. McClinton. And finally, we turn to Mr. Lorraine, who is not a first-timer before this committee. We welcome you back, and I recognize you for 5 minutes for your testimony.
Chairman Takano, Ranking Member Bost, and members of the committee, thank you for the invitation to testify before the committee today. Since I joined the military in the 1980s, both the military and veteran suicide rate has outpaced the non-veterans rates with only minor improvements. Personally, this is a disgrace. Professionally, it's a failure. And strategically, it's affecting our all-volunteer force. Together, we can do better. America's Warrior Partnership is working to bring us together, think differently, and demonstrate that as a nation, we can ensure someone has the back of all those who served. We aren't focused on an app or a website to end veteran suicide and self-injury mortality. We believe that proactive personal relationships formed at the community level, focused on looking forward to a thriving life, remains the key to improving the quality of life for veterans, their families, and their communities. Let me be clear, suicide and self-injury prevention needs to be the VA's #1 priority. We must think broadly to solve this problem. The solution isn't singularly mental health access, and it's not fair to place the burden on our healthcare providers. We're not going to counsel our way out of veteran suicide. The solution rests with all of us. Hopefulness is a protective factor. Hopeful for secure housing, strong relationships, spiritual connectedness, meaningful employment, reliable transportation, access to health care, the American dream, and the future. Accordingly, the question today must be focused on how can we identify and help those who've lost hope. 5 years ago, we started Operation Deep Dive to tackle the exact question. Operation Deep Dive gathered death data from 8 states and then corroborated the individualized data with the Department of Defense for former service members between the ages of 18 and 64 from 2014 to 2018. The results were alarming. We found that these states that we studied had a combined former service member accounting error of 25%. What that means is that they undercounted on average 17% of veterans who served as counting them as non-veterans, and those that never served in the military, 7% as having served. When combined, all the accounting of former service members who served on active duty or National Guard and Reserve who had been activated or deployed, these contributed to a 37% undercounting of suicide. Further, contrary to other reports, Operation Deep Dive had the data to investigate self-injury mortality. After finding a significant number of former service members were being listed as accidents and undetermined deaths, despite having similar manners of death to suicide, the biggest factor in this category was undoubtedly overdose. When combined, the suicide and self-injury mortality rates are 2.54 times greater than the VA reported suicide rate. It's not to make an equation, to couple them together, but just to demonstrate the extent of it, which equates to about 44 service members a day dying from non-natural causes each day. We identified during the study that every year served in the military reduces your reduction of probability of dying from taking your own life by 2%. Those with less than 3 years of military service were at greatest risk for suicide and self-injury mortality. Living with a partner decreased your odds of suicide and self-injury mortality by 40%. And dramatically receiving a demotion, increasing your odds of dying by suicide or self-injury mortality by 56%. Clearly, this data suggests that despite the VA's efforts, a mental health-centric, one-size-fits-all approach to suicide prevention is not working. In my written testimony, I've included recommendations to address the issue as well as recommendations for the Staff Sergeant Fox grant program. For years, the VA has used the suicide rate they publish as a metric to determine the program's success. This year, they reported another slight decrease. First, I think our data reflects that there's significant work to be done. Second, the VA must be more open and transparent about their data and share it with researchers as mandated by Congress. The VA's numbers and methods and how they are used is not clear, and the VA has not been open to sharing the data despite repeated efforts from other organizations and ourselves. Finally, the VA must investigate self-injury mortality further and include it in their reporting. The epidemic of overdose is on the horizon, and the VA needs to get out in front of it. Neglecting veterans' deaths because of the cause of death does not neatly match up within the lines of the VA, needs to be looked at. In closing, the data available to Operation Deep Dive is groundbreaking. There are more questions to be answered. In Phase 2, we've contracted with Duke University to further expand the study and the investigation. We're working to gain further data in 2020 and 2021 and expand the number of states participating. Thank you, sir, for your time.
I thank all the witnesses for their testimony. Their full statements will be included in the record without objection. I now recognize myself for 5 minutes. Well, actually 7 minutes. We're going to go to 7 minutes. We have such few folks here. So I want to begin with Chief Hoskin. I'm stunned at the percentage of Cherokee veterans who have reported suicidal thoughts to your health services personnel over the past 3 years. Over 80%. That's truly a heartbreaking number, sir. I'm impressed that your plans to launch a new Cherokee Nation veteran suicide prevention program with these VA funds is based on the zero suicide approach, which this committee advocates. We advocate that VA adopt that approach. Can you say more about the importance of this for your veterans?
Well, thank you, Mr. Chairman. And outreach is key, and not being passive on outreach, I think, is particularly important. And so in our culture, we are very much community-based. And so making sure our programs and services are community-based is very important. So on any given evening in the Cherokee Nation, there may be a community gathering that's focused on any number of focal points, could be culture, but we will have programs and services as part of these events. So I think being active and engaged in the community is our focus, rather than being passive and simply being in an office where a veteran might find her way to us. The other thing is the collaborative approach among our different departments. Our Veterans Office is a hub for veterans activity, but certainly the subject matter expertise is within our health department, our behavioral health department. And so a good working relationship between departments. I mean, Cherokee Nation is government that's relatively large in size. We have thousands of employees. And so making sure we're internally working together. I mean, all of the money in the world through a federal grant or other sources is not effective if we're not internally effective and talking to each other. And I think we've demonstrated that we have got a very good collaboration between departments, which I think can be effective. One thing I would note, Mr. Chairman, this goes beyond the scope of what you ask, is a great challenge in Indian country, and probably for much of the country, certainly rural America, is making sure we have enough professionals staffed and in the pipeline coming up to be able to take on these challenges. It is heartbreaking to think of that 80% statistic that you cited that I mentioned. Even more heartbreaking to think about veterans we may not reach because we may not have as many professionals on staff to reach them. We have to confront that, though. I think as a country, we certainly have to confront it as Cherokee Nation and make sure we're doing all we can to staff our programs with professionals. But certainly of the professionals we have and of the many more we will gather, collaboration internally is key, and external outreach, being engaged, is indispensable. Thank you, Mr. Chairman.
Well, I thank you for that, Chief. I appreciate your response, and especially your last comments about staffing. I often think that the debate we have here about care in the community versus internal capacity of the VA misses the point, especially in Indian country and in rural America. We simply don't have a way to get these practitioners out there. Pushing people into the community, I don't see how we push people in the community if there's no one in the community to take care of them. That is a fundamental problem. And frankly, I don't see how we stand up facilities or practitioners in these areas without some sort of federal presence. And so this debate, internal capacity versus care in the community, I think we have to move beyond that debate to ask the real question: how is it that we get practitioners and professionals and real staffing into rural America and Indian country? So, Ms. Humphreys, the Choctaw Nation has also had in place an incredibly sophisticated public health approach to suicide prevention for many years that includes substance use treatment, gun safety training, and case managers to engage people during high-risk periods. And you mentioned in your testimony that these new funds will allow you to hire peer recovery specialists. Can you say more about this effort?
Yes, I think that's our terminology, similar to what you were calling the buddies. And so hiring veterans that have this lived experience, whether they have struggled with recovery, mental health issues, even suicide ideation themselves, that's what we're speaking of for the peer recovery support specialist.
Well, thank you. And I understand that these peer support specialists, they probably do have some level of training, even though they have the lived experience, but they are at a place where they are able to take on this role and responsibility. So I want to move on to Ms. McClinton. I was intrigued with the important emphasis you placed on having Black veterans for social justice heavily involved in the outreach efforts in New York City. Can you say more about the kinds of outreach that you're going to be doing to reach veterans, especially those who aren't already engaged in VA, those who don't have a connection to VA?
Within Black Veterans for Social Justice, we have other community programs that we use on a daily basis. For example, every Wednesday, we bag, along with the Department of Veteran Services in New York, we package approximately 2,000 meals every Wednesday of food, fresh food that's processed, packaged, and then delivered to veterans, their families, and the community. So within those bags of food, there will also be either questionnaires or information that'll be talking about mental health. Do you have any of these symptoms? Are you experiencing anything? Are you in need of any other services that may cause you to go into these mental health traumas or episodes that way? We also have our HVRP programs. We also have our jobs to build on, different individuals and community events that we'll utilize and partner with other community events as well to do tabling and different type of telephone calling and the applications and the phone trees to make sure that the grassroots organizing aspect, the hands-on aspect, and reaching out and meeting these veterans where they're at within the community, and then also assessing at the same time. We have individuals that were staffed within our day-to-day operation when veterans come in, because we just don't serve Black veterans, we service all veterans and their families as well. So we're going to listen to and partner with family members where the veteran may not be able to ascertain what's going on. The family is maybe able to contact us, and we're able to reach them as well.
Well, thank you for your response. Ranking Member Boss, I recognize you for 7 minutes.
Yeah, thank you, Mr. Chairman. First of all, to our witnesses on the second panel, congratulations on being named as recipients of the Staff Sergeant Parker Gordon Fox grant. Now, Mr. Loran, how will this grant assist the AWP in its mission to reduce veteran suicide?
Ranking Member Bost, we have 5 branches throughout the United States. Alaska Warrior Partnership, the Permian Basin Warrior Partnership in Texas, Indianapolis Warrior Partnership, the Panhandle Warrior Partnership in Florida, and the Diné Nazba Partnership in the Navajo Nation. Those funds will be used to increase our outreach and engagement to veterans, build a relationship, really not only those who are seeking services, but those who aren't seeking services. Build a relationship with them. Understand where they want to be in their future, connect them to existing resources that are locally based or nationally based, and then stay with them on their journey as they go forward.
So now that you've been through the process, do you think that the grant award process could be improved?
It was pretty laborious. It was laborious and relatively short term in terms of how everybody else had to respond to it. Came out,
we had about 30 days to prepare for a pretty complex grant process. We are blessed to have it. I'm appreciative of the VA for recognizing our work, but it was tough.
Okay. Okay. Can you also elaborate on the major findings of Operation Deep Dive?
Yes. So the biggest finding was that the counties, the county officials and state officials didn't have the ability to recognize who served in the military and who didn't. One of our recommendations of the interim summary is that the Department of Defense and the Department of Veterans Affairs provide a website or a tool where coroners and medical examiners can enter somebody's name and social security number and then identify whether they served in the military. We saw that was a big, on average, it was a 25% miscount. Some states were 40%. And as a veteran myself, I'm troubled by the fact that there's a lot of veterans out there who were buried at their final without military honors, and that they should have been recognized, they should have been acknowledged, and they should have had recognition of their military service. But if you don't get the data right at the local level, it's not right by the time it gets up to the national level. So we've been very clear. This is not a VA. VA's using the data that they have available to them. If it's not accurate at the local level, it's not going to be accurate when it goes from the state to the CDC and over to the VA.
Yeah, one of the questions I asked the other panel was regarding the VBA and they're collecting their input when putting this together. What services, do you look at what services they're receiving, what things they've seen positive with the VA, where they've sought VA's help, whether they are access home loans, whether they, all of these things that are available to them, would that not also be important to have in a?
It'd be critical, but we don't have it. We have a three-piece puzzle. We have military service and we have death. We have the death record from the death certificate and we have their military service history. What I don't have is the middle piece, which is their VA experience, both VBA and VHA. If we had a complete picture of that, then when I read off some of the things that we found, we could add in access to VA home loans, access to VA, VBA, their disability benefits, et cetera, on top of their healthcare experience. Get a really good longitudinal picture from the time they began their service to the time they died.
Yeah, I think there's so many things that need to be in a report because when I said in my opening statement how complex, just identifying that somebody has committed suicide, we need to know what their background is, what was their service connection, what was their MOS in the service, what services have they been provided, what was their family situation, things like this, so that we can actually do the deep dive, not to steal the word, but to do the deep dive, to know. If we don't know the whole situation, it's very hard to fix the problem and identify problems to fix them. So what do you think it is that Congress can do? We've got the panel now. What do you think that we can do as Congress to help both you and the VA and community organizations like yours address veteran suicide more effective than what we are right now? Because we're not getting it done.
I think a big step was the Staff Sergeant Fox grant, pushing services down to the local level that focus on outreach and engagement and coordination of services are key. I think providing the state and county officials with access to a service that they can validate military service or not and get the data right. I think we can do a better job at understanding of using data to understand those at greatest risk. What we found was the veteran in Massachusetts looks very different than the veteran in Montana who's going to take their life. And the same thing in Florida. Florida, the panhandle of Florida veteran looks different than the Miami veteran who's going to take their life. And I think that that's where we can get to if together we can do better.
And I think that where was that veteran's time of service? We say all veterans, but we don't know whether it was a Vietnam veteran. Is it a veteran that is a Korean War veteran that's in the late term of their life and of that, or is it a new veteran just been released from service a year or two ago and he only served 2 or 3 years?
Yes, sir. One of the things that we were able to do with Operation Deep Dive is that we can look at length of service and time since discharge. So when someone came in, how long did they serve? Where did they serve? Did they have a deployment? Did they have a disability while they were on active duty? And then on the backside of it, we can look at the time since discharge. And one of the things that we see in discharge is, yeah, that first year is really important. But there's a spike at 3 and there's a spike at 20. And so we are not sure why. That's why when we go to Duke University, that's one of the things that we're looking at. And Duke is, it's the School of Medicine and it's their Department of Community and Public Health. We are focused on prevention at this point.
Yeah, we just got to keep working on it, and I thank everybody that's involved with it. Thank you, Chairman. I yield back.
Thank you, Ranking Member. I recognize Mr. Rosendale for 7 minutes.
Thank you much, Mr. Chair. Mr. Chair, I'll put you on the spot for a moment. I had a gentleman come to my office about 2 weeks ago. His name is David Williams, and he's an artist from Plains, Montana. And he, along with the Plains, Montana School District, created this beautiful, large 4 by 8 foot, okay, piece of art. It's a horse, and it is to recognize the Green Star families, the families that are suffering because they had one of their members that took their own life after being a veteran and being exposed. And I've got it up in my office. It's been signed by hundreds of people that were there at the Lincoln Memorial to support this effort that he brought out there on that day. And I don't know who has control over this decision, but I would like to work with you to see if we couldn't bring that piece of art in. It's utilized by local artisans to create the frame around it. It's truly beautiful. Please come to my office and look at it, because I think that the area right above that studio would be a grand place for it to be located, and that way every time that we have a hearing here, and I know this isn't our permanent room, but every time we have a hearing here, that all of the members could look up there at that piece of art and reflect upon the 22 or the 44 service members that are taking their lives every day, and make that a true priority. So if you would please consider that, I would sure appreciate it. And again, please come to the office and take a look. Mr. Rain, Operation Deep Dive is particularly important to me because Montana turned out to be one of the states studied. It brings me no joy to know that Montanans contributed to the 44 veterans per day that are taking their own lives. Montana is a unique state. Based on your familiarity with this project, can you give me insights as to what factors in Montana may have driven those numbers?
Yes, sir. In Montana, it's heavily rural, tribal areas. It's also access to health care. I think it's a tyranny of distance. You have to go so far to get health care. The other thing that we see is isolation, right? So in Montana, you're a rural state, and so it's tough to get between. I think the key is, and what we're advocating for, and I think what all my fellow panelists are advocating for, is let's go out and find and build a relationship with the veterans where they are, understand what they need, connect them to those services. But I think in Montana, you were the most rural state that we studied.
I appreciate that. And that being said, I've been working with several groups within the state to address this problem. We've got the Warriors and Quiet Waters project up in Bozeman. They do an incredible work. And also some folks down in Texas started the Overwatch project. And anyone who happens to be listening today, if they're having any thoughts or they think a friend of theirs may be, the overwatchproject.org. There's information online to immediately try to deliver some support for these individuals. It really bothers me deeply that anyone, but certainly those who fought to protect our nation, would sink into a spot where they don't recognize their own value, because we all recognize that they have value. How granular, Mr. Lorraine, is your data? Modern day warfare, as Mr. Boss was just speaking about, puts very different kinds of strains on different troops. We've got special operators, we have drone pilots. Many of our troops have rotated through Iraq, Afghanistan, while others continue to be stationed in Kosovo. Do you have enough data to tell where troops served and in what theater?
Sir, we do. Related to if you served post 9/11, we have, the Department of Defense has been a great partner. We have data that identifies deployments and the location of deployments. It also identifies locations of assignment. So it's not just the deployments, but those who were stationed at Camp Lejeune, or those who were stationed at Anniston, or those who were stationed at other places that might be of interest on the non-suicide, but on the health side. On toxic exposure, et cetera. We have really pretty granular data. The other piece of data that we have is that we see the full career of someone who served. So we know that somebody who went into the reserves, served on active duty for a little while, and then went in the National Guard, we know that they had actually active duty time, so that we can identify those we call as former service members, and we can account for them. We didn't account for, in the study, we didn't account for pure National Guard or pure Reserve who didn't have a deployment that was a lengthy deployment.
So after you've reviewed the data, have you been able to identify the areas where you have holes that you want to go back in and fill in, or is that what the next step is going to be?
Yeah, that's the next step, but some of the holes are is National Guard or Reserve service a protective factor? If you get out of active duty and go into the National Guard or Reserve, is that a protective factor? What's the impact of the characterization of discharge? What's the impact of moving multiple times? We would love to have the VA data and partner. I just want to say the VA was part of the IRB. A VA employee researcher was part of our study. And that was important. That's the reason why we didn't classify people as veterans. We classified them as former service members.
Okay.
Yes, sir.
Thank you. The last thing I'd like to say is I really, really appreciate everyone that's participating today, and each one of you, your comments in reference to opening your doors up to everyone. I think that you recognize that there's mental health problems across the entire population, and for each one of you to recognize that and open your doors up is commendable, and I really, truly appreciate it. Thank you. Mr. Chair, we yield back.
Thank you, Mr. Rosendale. Go back to my... So I'd like to thank our second panel of witnesses. I'd like to thank each of you for your attendance at today's hearing. You're absolutely invaluable voices in this conversation, and I have great hope for the work you will do with the new VA grant funding. So congratulations to all of you. To everyone who testified today, and to those of you listening, and most importantly to veterans and your families, you have my commitment that we will continue our bipartisan focus on veteran suicide prevention as a top priority for the committee. I also applaud VA's dedication and adaptability. Your comprehensive efforts are encouraging, but with roughly 16 veterans lost to suicide each day, we can't relent on our shared goal to more drastically reduce the rate of veteran suicide. And so this committee will continue its work with our Senate colleagues to advance pending suicide legislation with VA to ensure effective implementation of current law, and with veterans to ensure that we continue to offer hope, solace, and opportunity. I now recognize Ranking Member Boss for any closing remarks to
Yeah, thank you. Thank you, Mr. Chairman. You know, I'd like to once again thank the witnesses for being here and sharing their experience with the committee. I look forward to continuing to work with everyone here to end veteran suicide. And, you know, VA knows how to save lives, but they can't do it alone. The Secretary must keep working with others to better identify and understand the most important factors in effectively helping veterans in crisis. Until then, our solution will have blind spots, and sadly, the suicide numbers remain too high. Every door must be open when a veteran seeks help. And to my fellow veterans, I want to say there is no shame in weakness, in our weakness in asking for help. No matter what the suicide is, no matter what, suicide is never the answer. I always say it is a permanent problem or permanent solution to a temporary problem. If you think you might be in that situation, please, I beg you, we've got the 988 number. It's call 988 and press 1. You can text 838-255, or you can visit crisisline.net. You're not alone. You're worth it. You matter. And you need to know that. And with that, Mr. Chairman, I yield back.
Well, thank you, Ranking Member Bost. All members will have 5 legislative days to revise and extend their remarks and include extraneous material. And again, I thank everyone for appearing before us today. And this hearing is now adjourned.
Thank you.